Hello, everyone, and welcome to our video on pulmonary physiology. This video, we're going to focus a lot on graphs because a lot of people, they really hate math and they don't like graphs. And so for you guys, I hope this video will be helpful. In order to understand pulmonary physiology, let's take a look at this graph that first aid has laid out for us. So here you see the pattern of breathing that results when you hook somebody up to a spirometer. And here we see the tidal volume. So this is a person's breathing at rest, just quiet breathing, which oscillates from about 2.2 to 2.7 liters of volume in the lung. And then if they take a deep breath in, this volume can increase to about 6 liters. And when they breathe out really quickly, it can decrease all the way down to 1.2 liters. And then you can breathe in again and go to your tidal volume here. So this part right here is going to be important because when you breathe out quickly, there's something that doctors like to measure called FEV1, as I'm sure you guys know. And FEV1 is the forced expiratory volume in 1 second. And they like to compare that volume to the FVC, or the forced vital capacity, which is this entire graph here. So let's zoom out here and let's look at what Boards and Beyond Dr. Ryan has told us about FEV1 and FVC. So on spirometry, this is what you guys can see on your test. And you can see here as time goes on, a patient will breathe out very quickly and then their breathing will slow down as they run out of volume in their lungs. And this ratio, this FEV1 to FVC ratio, helps us distinguish between obstructive and restrictive disorders. So this graph here demonstrates that really well. In obstructive and restrictive disorders, there's going to be a decrease in the total lung volume, the total amount of air that the patient can breathe out, the total amount of air the patient can breathe out in total. So that's why these lines end lower. And the FEV1 will be severely decreased in obstructive disease because the patient has trouble breathing out as fast as they do in the normal lung or restrictive disease, where their airways are still patent, but they don't have enough air in their lungs. And so that's why this graphical relationship can be summarized in this table. So you can see here that restrictive disorders have an FEV1 over FVC of over 80%, which is 8.8 is normal and over 80% is higher than normal. So the rate at which they can expire in a restrictive disorder is going to be compared to the FVC, the forced vital capacity, or the amount of volume they can hold in their lungs, is going to be elevated because they can still expire quickly, but the amount of air they can expire is low as well. So in obstructive diseases, this is not the case. The FEV1 will be decreased because they cannot expire as quickly. Okay. So now that we got through that part, let's go on to another graph. All right, this is just the same graph that I showed you guys earlier. So this is another version of a spirogram. So you can see here, this one is laid out a little bit differently. So this one starts up this is the normal graph here in blue. And this here is the total lung capacity. So this person is holding their breath in, and then quickly they breathe out, and the amount of air in their lungs decreases very quickly. So over here in 1 second, this part of the graph will correspond to the FEV1, forced expiratory volume, in 1 second. And you can see that restrictive diseases have a graph starting at a lower point. The TLC is lower, total lung capacity is lower, because their lungs are restricted. They can't hold as much air in them. So when they breathe out, they can still breathe out quickly and breathe out as much air as a normal lung, but they cannot start at a higher amount of volume. Obstructive diseases, on the other hand, their lungs are hyperinflated. Patients with obstructive disease have hyperinflated lungs. And so when they breathe out very slowly, and then they can return to a much greater volume because they're holding so much air in their lungs. All right, and now here we get to flow volume loops. So first aid has a really good chart here that I want to describe to you guys and tell you how you can identify this on your exams. So as you can see, this is the normal flow volume loop, and let's follow this as a person breathes. So here on the left side of this red graph, we see that there are higher lung volumes, and on the right, there are lower lung volumes. So from the lower lung volume, this is an a point of maximum expiration. And as we go to a higher lung volume, this way, this would be the patient's inspiration. So this patient is inspiring. And then very quickly, the flow of air is in the positive direction. You can see here this axis, the flow of air is in the positive direction. And quickly, this FEV1 here will reach a peak, and then the flow of air will decrease as they're not able to force as much air out of their lungs since some air has already left. So this graph will follow this direction as the patient is breathing over the course of time. So let's first look at obstructive disease. In obstructive disease, as we mentioned earlier, there's going to be more air into the lungs. So this relationship between the lowest point in the graph and the highest will shift to the left. So in this case, it's the left, but they can give it to you on the test flipped. So the left corresponds to more volumes in the lungs. So obstructive disease, patients with obstructive disease have more volume in their lungs. That's why this graph will shift to the left in this case. They can still inspire relatively normally, but when they expire, there's not a lot of air that they can push out. So this peak expiratory flow will decrease dramatically because they can breathe out quickly, yes, but then, they can breathe out, but it won't be as fast as the normal lung, right? Because they're obstructed, that's right, sorry. They're obstructed, so when they breathe out, they breathe out very slowly, and this peak will not reach the normal lung. In restrictive disease, this is what I meant to say earlier. In restrictive disease, this peak will peak similarly, but they don't have enough air in their lungs as compared to the normal lung. So although it will peak in a similar pattern, it cannot reach the same 8 liters per second that this normal patient will reach. And you can also see that this relationship between the minimum amount of air in their lungs and the maximum amount of air is shifted to the right, because they can hold less air into their lungs, right? Okay, and the last graph that I wanted to review with you guys is work of breathing, which came up on a UWorld question for me, and it really stumped me. It was a very tough question. So if you look here, there are 2 relationships that influence work of breathing that Dr. Ryan points out to us from Boards and Beyond. So the first relationship is airflow. As you breathe faster, the flow of air increases, and the turbulence of the air also increases. So the faster you breathe, the harder it is to breathe based on the airflow relationship, because the faster you breathe, the more turbulent the air is. Okay, and now there's also another relationship with elasticity. So the faster you breathe, the less time your airways have to collapse in on themselves. And the slower you breathe, the more time the airways have to collapse in on themselves. The alveoli have a tendency to collapse, as you guys learned with surfactant, and that relationship with lack of surfactant will give you more collapsing pressure. So in this relationship, it is worthwhile, if you just think about this relationship, it is worthwhile for the patient to breathe at a faster rate. And with this relationship, it's worthwhile for a patient to breathe at a slower rate. And they both combine to form this graph over here. So the truth is, the work of breathing is lower somewhere in the middle, where the elastic forces and the airflow forces minimize somewhere at this point. So this lowest point is the lowest work of breathing that a normal lung can sustain. So this is where we usually breathe. And Dr. Ryan says it's around 15 to 20 breaths per minute. Now, what happens in obstructive and restrictive disease? Well, in obstructive disease, let's look at that first. So patients with obstructive disease have a low have a low respiratory rate. And the reason for that is because they have more airflow resistance. They're obstructed. So if we look at this airflow resistance relationship, they'd like to minimize this. They don't want to breathe here. They want to breathe here because they have a lot of turbulence when they breathe. So they want to breathe at a slower rate. And when we look at this graph, we can see that from the normal, it's shifted up and to the left. So this airflow part, this purple line here, will be shifted upwards. Like with the same slope, it's going to shift upwards, and it's going to push this graph, this red part of the graph, up like that. That's why patients with obstructive disease, they tend to breathe slower. And this kind of logically makes sense if you think about a patient with asthma, or you think about a patient with COPD and you watch them breathe, they're going to take long, deep breaths like this. And that's because they have a lot of resistance to airflow, and they want to minimize that resistance and take slower breaths. All right. Now let's talk about restrictive diseases. So in patients with a restrictive lung disease, they want to take faster breaths. And the reason for that is they don't want their airways to collapse in on themselves. So since they have a lot of fibrosis in their lungs want to collapse in, and they want to prevent that from happening. So the faster they breathe, the easier it is for them to prevent that from happening. And if you look at this elastic graph, this relationship between elasticity of the lung and work of breathing, you can see that in restrictive disease, this line is pushed up this way. So from normal, it'll be pushed up and to the right like this. And so that's why the breaths per minute of a patient at rest with restrictive disease will be slightly higher than normal usually. And that is all I wanted to share with you guys regarding the graphs. Here's a pop quiz. These are all the graphs we talked about, and I want you guys to label which lines are restrictive diseases and which lines are obstructive diseases. And after you pause the video and label them, here are the answers for you. And that's it. If you guys understand this, any graphical physiology question, you'll be able to get right. And if you have any questions about this, you can email me or you can review the video to see why these graphs are the way they are. And also there's a lot of other pulmonary physiology I didn't want to touch upon, and I put it in here for you guys. In case you want me to touch upon anything here, if you feel like, this stuff is constantly stumping you, just send me an email, smoothbuttermd@gmail.com, or comment on this video, or ask a friend. I don't know. Our friends are really helpful sometimes. Okay, that's it, guys. Thanks for watching the video.